Hello students, this is Dr. Archith Boloor. So we have had your INI-CET exams and now we are going to do a recall session. As the feedback, as usual, the basic sciences part was a little tougher compared to the clinical subjects that you had. And the clinical subjects were more maybe clinically oriented questions were asked. We had almost around 25 to 26 questions directly from medicine. And I think with the correlation with pathology and other subjects, we had more questions. So let's discuss what are the possible answers or what were the questions that came in this part. Again, as we had discussed in our, we had PYQs, the endocrine part, the cardiology infectious diseases did have a good weightage. We did not have much from the seizures and epilepsy section that is there. Endocrine diseases did have much questions that came this time, which was predictable that was there. Most of the questions had a clinical correlation that was there and image, etc. was there. And you could narrow down the options, and in most of them, we could localize one particular option as the right option that we have. So let's discuss the questions that came this time. So we had some questions on COPD and I think 2 questions directly from the severe COPD that came up. So if you look at the first question that we have here, so according to the GOLD guideline, what is the FEV1 percentage or the FEV1 predicted cutoff associated with clinically significant resting hypoxemia in patients with chronic COPD? Now, GOLD guidelines updated in 2024. That was the last update that we had. Now, here the clue that was given was the patient had clinically significant resting hypoxemia. That means the saturation itself was low. What is the FEV1 at that point? So it means this patient has a severe COPD. So that is what we have to remember. This patient had a severe COPD compared to what we have. So when we have a severe COPD, the GOLD classification would say that the cutoff for the FEV1 should be less than 30%. So the answer here primarily is 30%. So that's the answer for this. So significant resting hypoxemia, that means this patient has definitely severe COPD that we see there. So if you see here, the FEV1 predicted mild has more than 80%, moderate is 50 to 79%, severe is 30 to 49, and very severe. That's when we say the hypoxemia, resting hypoxemia usually happens when the patient has severe COPD. The partial pressure oxygen is very low there. So the answer for this question is 30%. So it is predicted to be less than 30%. So the option D is the correct option here. And as far as GOLD says, less than 30% predicted or less than 1 liter is the cutoff, which is mostly associated with hypoxemia as per the GOLD guidelines. The second question again was from COPD. The GOLD guidelines, this patient has come with the acute exacerbation of COPD. That's what is said. There is tachypnea, there is tachycardia, there is increasing sputum, and the saturation is 90% on room wear. And what we are seeing is carbon dioxide is high. So this patient has hypoxia as well as hypercarbia. So this patient has type 2 respiratory failure that we are looking at. So and an acute exacerbation. Patients, they're not mentioned about the consciousness states. So what are the measures that we use for treatment of acute exacerbation of COPD? That's our question that's been asked here. So antibiotics, systemic corticosteroids, antivirals, nebulized bronchodilators. So this patient has an acute dyspnea. So obviously the mainstay therapy is to give bronchodilators. So nebulized bronchodilators is definitely to be given. Acute exacerbation, systemic corticosteroids are definitely useful here. Antiviral treatment, antiviral, though the viruses are the common cause of exacerbation, we do not use routinely antiviral. So C is not there. Now, is antibiotics indicated? Now, here, any acute exacerbation, especially when there is an increase in the sputum, they have written here increase in the sputum, is warranted for antibiotics. You send the sputum as well as start the patient on antibiotics. And here, very importantly, when the PCO2 is high, that means these patients would require some sort of a non-invasive ventilation. So BiPAP would be indicated in these patients. However, that option is not there. So the answer is A, C, and D. So sorry, A, B, and D. So A, B, and D are correct. C is not there. So the option that is correct is A, that is in this case. So that's what you're looking at when you see an acute exacerbation. We would start controlled oxygen. That's not an option there. You don't allow the oxygen to be given too much because otherwise the PCO2 will increase. BiPAP is something which should have been there in the option, which is not there. Bronchodilators, steroids, and antibiotics are standard management for exacerbation. Now, a patient with the OPD comes in with back pain and weakness of both limbs. Which of the following is suggestive of compressive myelopathy? So compressive myelopathy, that means there is a spinal cord compression and producing the weakness in the lower limbs. So it is an upper motor neuron disease. That is something that you have to remember. So it's an UMN disease. So classically, you will have increased tone, increased reflexor. You will have an exaggerated reflexes, clonus will be there. Plantar will be extensor bilaterally, definite sensory level and bowel bladder involvement. So that is the hallmark if you see there. So there will be spasticity, there is hyperreflexia, positive or extensor plantar response, sensory level, definite sensory level is needed. May not be always acutely, it may come later. Bowel bladder involvement. At the level of compression, you may have element signs, at the level. So they have not given us that clue here. So if you look at the options, hypotonia is wrong. So it's a UMN disease. So hypotonia cannot happen. Normal cribrastic reflex. So in UMN disease, the reflexes are absent. The superficial reflexes get absent. Babinski sign should be present. Okay, it should come. So there should be a Babinski sign there. So that is also wrong there. So what is definitely a feature of UMN is the clonus. So this is the correct option. So knee clonus that is there in this patient is possibly the correct answer. So D is the answer for this case. A patient comes to the OPD with fever, no bleeding manifestations, vitals are stable. Blood workup shows a HB of 9, platelets is 20,000. So you have a fever, acute febrile illness with the thrombocytopenia. So you could have various causes. It could be malaria, it could be dengue that could be seen. So here they have not given what's the diagnosis. If you take the complete all over India, most common cause would be dengue now. Malaria is much lesser. What is against dengue is the hemoglobin. So remember, hemoglobin usually in dengue is hemoconcentration. We don't get low hemoglobins. But let's consider that it is dengue only. So this patient has dengue. What is the next step to manage? So this patient's vitals are stable. So they say there is no postural blood pressure. There is no warning signs that's there. So it's possibly a mild dengue. So is it paracetamol? Is it antibiotics, platelet transfusion or steroids? Definitely for the fever, we give paracetamol, that is given. Antibiotics are not to be given. Now platelet transfusion, so all of us know the indication of platelet transfusion is only when there is active bleeding, okay, or the platelets is very low, 10,000 or below, then it is there. Steroids are not to be given in dengue unless it goes into a complication like a HLH or a macrophage activation. So the answer for this is D. So please remember dengue. This is classical presentation, dengue without warning signs, where the hematocrit is increased, the platelets are decreased, but the patient has no other complications. There are no warning signs. There is no severe dengue. And please remember, platelet transfusion is not indicated unless there is severe thrombocytopenia or there is 20,000 with bleeding. Then we can give platelet transfusion. So the answer is only paracetamol here. Patient is diagnosed with recurrent peptic ulcers and a nodule in the first part of the duodenum. Which of the following tests is indicated? Now remember, recurrent peptic ulcer, very, very important thing that we have to remember, recurrent peptic ulcers, it could be due to increased gastrin level. That is your Zollinger-Ellison syndrome. So that is your disease that we are thinking of. You could get recurrent peptic ulcers due to infections, H. pylori, it could be reflux disease, it can be hyperparathyroidism also. But here they have given that there is some nodule in the duodenum. So you know that it is probably arising from the pancreas there. So pancreatic islet cell tumor possibly, which is secreting gastrin. So our diagnosis is Zollinger-Ellison syndrome. So for the diagnosis of Zollinger-Ellison syndrome, we do the basic serum gastrin levels. Prolactin is not here. Urine catecholamines is for the pheochromocytoma. Parathormone, yes, hyperparathyroidism causes recurrent GI ulcers, they can have pancreatitis also can happen. But here, the duodenal lesion is the one which is against that part that is seen. So the answer here is the gastrin levels. So fasting gastrin levels more than 1000 picograms with the gastric pH less than 2 is diagnostic of gastrinoma. And later you will have to localize the tumor by doing a PET scans. You can do the somatostatin scans can be done, and that can diagnose the gastrinoma specifically. A 28-year-old male presents with involuntary jerky movements of the face and limbs, along with noticeable personality changes. And increased forgetfulness. So this is the brain MRI shown. So it's a young patient, involuntary jerky movements on the face and limbs. So this is the characteristic appearance of a chorea, right? Chorea, purposeless inversely jerky movements of face. And there is personality changes and there is forgetfulness. And this is the classical MRI. You can see there the caudate, caudate atrophy that is seen, and you can see the box car appearance of the ventricles. Little atrophy is there. So this is very characteristic. Chorea, you have either two options here. Wilson's produces wing beating tremor. Prion disease only produces dementia. Sydenham's chorea is seen in rheumatic fever, right? So acute rheumatic fever patient, usually a female, after 6 months of your carditis, etc., they come with chorea, milkmaid sign, etc. Huntington's disease is a degenerative. It's a neurodegenerative trinucleotide repeat disease where you have personality changes and forgetfulness also. So the classical boxcar ventricle that has been described here, dilated frontal Hans, you can see there, and a caudate nuclear atrophy. This is classical of your Huntington's disease. Now the large P waves. Now P waves is produced by the atrial activation. So whichever condition produces a big, large atrium will produce large P waves. So here, mitral stenosis, there is left atrial enlargement. Mitral regurgitation, also there is left atrial enlargement. Aortic regurgitation, you don't have. Systemic hypertension, there will be an LAE later because of diastolic pressure overload that is seen. So actually, the three options are correct in these conditions. So when we say large, it could be tall, it could be bifid. So most likely here they are meaning is bifid or a broad P wave, which is classically seen in MS, MR, and systemic hypertension. So the options that are correct are A, B, and D. Aortic regurgitation very, very rarely produces. Tall P waves, P pulmonale, which you see in case of pulmonary disease, right? Or Epstein's anomaly or pulmonary stenosis or tricuspid stenosis. So here it's a multiple option question. So you get it in 3. It is not seen in aortic regurgitation classically. Now, which of the following condition does not share the underlying mechanism that contributes to development of heart failure as seen in other conditions? Anemia, fever, high salt intake, thyrotoxicosis. Now here it's a very clean picture that I have given very clinically. We call this high output cardiac failure, right? So increased cardiac output and heart failure seen in anemia, thyrotoxicosis, fever, beriberi, AV fistula, sometimes with cirrhosis and pregnancy. So these are high output cardiac failure that you'd see there. High salt intake, not usually associated with heart failure. So the option which very rarely it can cause, okay, high salt intake, that could be natriuresis, etc. usually happens there. So high salt intake is not the mechanism because there is no increased cardiac output. Anemia, fever, and thyrotoxicosis will have high output cardiac failure that you see there. 25-year-old SLE patient, weight gain, moon face, buffalo hump, hirsutism. So this patient is SLE, so she's on immunological therapy and she's developed the Cushing. So the cause of Cushing's here, very clearly, it's due to the steroid. So it's a steroid-induced Cushing's disease that we're looking at. So what is the diagnostic test that we do for a steroid-induced Cushing's? So is it the serum ACTH and a low-dose dexamethasone? Low-dose dexamethasone suppression test, high-dose dexamethasone suppression test, serum ACTH or cortisol levels. Please remember, for Cushing's, we do the dexamethasone suppression test. You do the low-dose and followed by the high-dose that is seen. That is for the endogenous Cushing that you do it. But for the exogenous Cushing, remember, there is a decreased cortisol and a decreased ACTH because that is because of a suppressed, HPA axis is suppressed. Whereas endogenous, there is increased cortisol, increased or normal ACTH that could be seen based on what cause it is there, variable ACTH. So the test that we are supposed to differentiate whether it is endogenous or an exogenous is D. So option D is the correct answer. Later, once we see if it is not an exogenous, here it is definitely exogenous because this patient is lupus on steroids, right? So it is a definitely exogenous source that's there. So ACTH and cortisol levels will differentiate it. And if that is low, then your diagnosis is clear. If it was Cushing's disease or Cushing syndrome, then we had to do the dexamethasone suppression test. A 55-year-old chronic smoker presents with right-sided ptosis, meiosis, anhidrosis, and right hand intrinsic muscle weakness. Chest X-ray is showing this. What is the next base? So please remember, smoker coming with all these features, classical features of Horner syndrome, right? So Horner syndrome this patient has. So, and you can see a mass here. You can see the mass with the rib erosion. So this is the classical Pancoast tumor. So what's the next diagnosis? So your diagnosis is Pancoast tumor here. What do you want to do? So is it NCV? Is it CT guided biopsy? Is it ultrasound? It's sputum cytology. Among this, so you have made a diagnosis of Pancoast tumor. So you know what type of tumor. So the best option here is CT guided biopsy. Now, the question is for the malignancy. So it's a Pancoast because they have shown a superior sulcal tumor here. Now, for the diagnosis of Horner's, if you want to make out whether the nerve is involved, ideally an MRI is indicated. But here we require a diagnosis also. What is the cause for the this lesion here is seen in the upper part here with rib erosions. Then a CT guided biopsy is the best investigation to diagnose it. So chest X-ray will show the opacity there. CCT will identify it. MRI would show whether the brachial plexus and vertebral invasion that is there. That's only done if it is needed. CT guided biopsy is the histological. So we require this as the main test. So the answer is CT guided biopsy. Now, which of the following is not typically seen in Conn syndrome? Now, Conn syndrome, where you have a primary hyperaldosteronism, which comes with the triad of, remember the primary hyperaldosteronism, triad of hypertension, metabolic alkalosis with hypokalemia. That's the triad. Sodium is a little high, but usually not higher. It's a normal sodium. Now, that's very important that you have to remember. Whenever there is a hypertension, there is a retained sodium that is there, and that produces natriuresis. Okay, so that is why there is no frank hypernatremia. Very, very rare to get hypernatremia. Though you might find a higher normal or a normal level, but you'll never have a hypernatremia that you see in Conns. So the answer which is right is A here in this case, which is not a feature of Conns. So as we said, there is a mild increase, but then as we said, pressure natriuresis that will decrease it. Potassium secretion producing hypokalemia, metabolic alkalosis, and there is a hypertension. So that's the Conns disease. Which is the most common site for berry aneurysm? So all of you know this. It is the junction of the ACA with the ACOM. So ACA with the ACOM junction is the most common. So here the option which is there closest to that is the anterior cerebral artery. So if you look at the statistics, the junction between the ACOM is most common. Almost 40% is because of that. Posterior communicating is with the ICA junction is around 25 to 30%. Bifurcation of middle cerebral artery is 10%, and basilar and vertebral is less than 10% that is seen. So ACOM to ACA communication. So ACA is the correct answer. A patient with hypothyroidism recently had a long hour flight. Which of the following contributes to a risk factor for DVT in her? So what are the risk factors for a prolonged? So prolonged immobilization, definite is key. Smoking, definite. OCP, definite. Now, is hypothyroidism a risk? That's a question, whether it is ABCD or it is ABD. Now, remember, hypothyroidism traditionally is not considered as a risk, though hyperthyroidism produces a lot of hypercholesterolemia is associated, and it can produce arterial thrombosis. For venous thrombosis, hypercholesterolemia is not a strong cause. So the answer is A, B, and D. That's the answer for this option. A, B, and D is the option here. And you should remember, hyperthyroidism has a more chance of developing the DVT risk rather than hypothyroidism. So prolonged immobilization, smoking, and OCPs are direct risk factors for developing DVT. 40-year-old HIV patient presents with cough and hemoptysis. CD4 is 50. X-ray is showing this. You can see there upper lobe lesion there with some cavitation. So what's your disease? Tuberculosis. So this patient has tuberculosis as the diagnosis. Now again, remember CD4 low, more the low, by around 200 only you will start getting tuberculosis. But as the CD4 is much lower, you will have more probability getting the disease. It is not a bronchogenic carcinoma. It's not a metastatic lung disease. Lung abscess, you should have had an air fluid level that is not seen in this condition. Remember, when the CD4 is lower, you will have a chance of atypical mycobacteria also, MAC also. But MAC does not produce the upper lobe lesion. It usually produces middle lobe lesions with the lymphadenopathy and organomegaly. So among these options, C, pulmonary tuberculosis is the correct option that you have. A child presents with recurrent lung infections, a continuous murmur is heard in the subclavicular or infraclavicular area. Continuous murmur is heard. So remember the causes of continuous murmur we have discussed. Most important is patent ductus arteriosus. You can get it in the aortopulmonary indio, the RSOV, the Al-Kappa, etc. So among these, the PDA, this is a acyanotic heart disease, which classically produces the machinery murmur. Okay, continuous murmur in the infraclavicular area. This is the answer. PDA is the answer for this. Which of the following clinical conditions are correctly matched with the anion gap? Starvation, increased anion gap. Diabetes, increased anion gap. Severe manner, vomiting, anion gap, increased. So that's a straightforward question here. Remember, starvation produces anion gap acidosis. Diabetic ketoacidosis also increased anion gap. Severe vomitum produces alkalosis. So the answer here is A and B are correct. So you get A and B is correct. These are the two options. The C is wrong because it produces alkalosis, not acidosis in this patient. 30-year-old RTA, 2 episodes of vomiting, initially conscious and oriented, then the worsened, became drowsy, and is now in stupor and coma. And you can see here classically the bicon vex with an extra, there is a lesion there outside the skull also. So this is the classical EDH. And you find that there is a midline shift that's happening. So what is the treatment for this? So it cannot be conservative. Mannitol should not be given for EDH and SDH. Is it craniectomy or a burr hole? So we have to do a burr hole evacuation. Okay. So craniotomy, not craniectomy. Craniectomy is indicated when there is a large lesion which is producing which is a brain lesion. Okay, inside the cortex. This lesion is outside the cortex. So you can remove the clot and it can. You have a large infarct which is producing raised ICT. That's when you do the craniectomy. You remove the skull. You open the skull, take a flap, and then remove the flap and keep it open. Just cover it by the skin so that the brain can expand outside. Whereas here that is not needed. The problem is bleeding outside, so which can be emergently because the patient is already going into become drowsy and he's coning. So you'll have to do it as an emergency. Child comes with diabetic ketoacidosis, sugar is 400, pH is 7, very low. So severe acidosis, potassium is 4. So diabetic ketoacidosis, what's the management? Very, very important. You will have to hydrate the patient. So normal saline is the fluid of choice for hydration. You give 10 to 20 ml per kg of normal saline, followed by insulin infusion. That is what is given. Now the option here is normal saline with insulin with KCl and bicarbonate. Normal saline with insulin, KCl and KCl 40 milliequivalents. Bringalactate, we don't use it. So among these options, now severe acidosis is there. Do you want to give bicarbonate or not? Now remember, this acidosis usually responds to saline. Unless the patient is having severe acidosis not responsive to saline, then only we give bicarbonate. Because bicarbonate giving can cause severe hypotension, can worsen the situation. So bicarbonate need not be given straight out. We can give it later. Now, do you want to give 20 milliequivalents or 40 milliequivalents? So ideally, we would start with a higher dose because insulin is going to push the potassium inside. So the option correct is B. Okay. Even after doing this, if the bicarb is low, then possibly we may give a patient a bicarbonate correction. Otherwise, we don't give the bicarbonate correction. Laboratory evaluation, hemoglobin is low, MCV is low. So it is a high microcytic anemia. So what are the causes of microcytic anemia? Remember, iron deficiency, thalassemia, lead poisoning, iron deficiency, thalassemia, lead toxicity, vitamin B12 deficiency. The vitamin B12 deficiency, we know it is macrocytic, not micro. The other three are microcytic. So answer is ABC. Other conditions where you can get microcytic is sideroblastic anemia and sometimes with anemia of chronic disease, rarely with copper deficiency. But vitamin B12 deficiency produces macro. So the answer is A, B, and C. Child presents with proteinuria that is not responding to corticosteroid therapy. So it's a steroid-resistant nephrotic syndrome. And classically, you're seeing the segmental areas of sclerosis. So what's the diagnosis? It is not minimal change disease because there is no sclerosis. IgA nephropathy is in adults. Membranous is in adults. Focal segmental glomeruli, segmental areas of sclerosis. So your answer is FSGS. Again, a very important cause of nephrotic syndrome in children, which is steroid resistant. That is what we have to remember. Renal segment is showing the sclerosis. So your FSGS is the cause. Woman with dry eyes, gritty eyes sensation, bilateral salivary gland evaluation. She has hypokalemia and metabolic acidosis. So what is this diagnosis? So you have dry eyes, grittiness. So your diagnosis is a Sjögren syndrome. And hypokalemia metabolic acidosis is a renal tubular acidosis this patient is having. So what is your diagnostic test? You can do the Schirmer's test for the eyes and the autoantibody profile. So you can get the specific antibodies that could be positive, and you can do the urinary electrolytes to make out the renal tubular acidosis diagnosis. Serum calcium and AC levels is for your sarcoidosis. Acetylcholine receptor antibodies for myasthenia gravis. Salivary gland scintigraphy we don't usually do. It can be done for sarcoidosis, not for the Sjögren's. Which of the following drugs is used as a treatment of pulmonary hypertension, which is a prostacyclin receptor antagonist? Is it selexipag? Is it ambrisentan, epoprostenol, iloprost? So you have your epoprostenol and iloprost are prostaglandin. Ambrisentan is an endothelin receptor antagonist. The prostacyclin receptor antagonist is selexipag. So selexipag is the answer. So if you look at the various diagnostic your drugs which are available for treatment of pulmonary hypertension. So pulmonary hypertension can be treated with endothelin receptor antagonists like bosentan, ambrisentan, phosphodiesterase inhibitor, sildenafil and tadalafil, soluble guanine cyclase inhibitor, the riociguat, the prostacyclin analogs, epoprostenol, tripoprosten, iloprost, and the prostacyclin receptor agonist, that is the selexipag. That is what we use for the treatment for this. Which of the following is considered as the most appropriate initial diagnostic test for Cushing's? So here it is Cushing's disease or Cushing's syndrome. So you want to know whether the cause is whether it is the Cushing's due to the pituitary or Cushing's due to the adrenal. So here the main test that helps us to differentiate is the dexamethasone suppression test that we do. 24-hour urinary precortisol is not indicated. ACTH level and dexamethasone suppression test, fasting, DST, that may not be. So low dose and high dose. So start with low dose, and then if you want to look for a paraneoplastic or not suppressing, then we do a high dose dexamethasone suppression test. That's the gold standard. Now serum cortisol and ACTH stimulation, that's your ACTH stimulation test which we do for Addison's, not for Cushing. So the answer is B here. So overnight 1 milligram dexamethasone suppression test is the diagnostic test. After that, you can do the plasma ACTH to differentiate between whether this patient is having primary or secondary cause that is there. So ACTH levels and the fasting DST, that is the third option. So C is the most likely to identify Cushing syndrome. Sorry. So to identify Cushing syndrome, ACTH levels and the 1 milligram dexamethasone suppression test can be used. Later, you might require to do the high dose dexamethasone suppression test. Child with bronchial asthma develops central obesity, moon phase, tria. What is the most likely cause? So bronchial asthma possibly is on exogenous steroids. So that's the most common Cushingoid features that is producing. Progression of the disease does not produce it. Adrenal hyperplasia and pituitary adenoma is very rare to cause that. So use of exogenous steroid, either oral steroids, which produces this Cushing's rather than the inhaled steroids that we have. What is the primary cause of the decrease in systemic arterial blood pressure observed during inspiration? Now, during inspiration, why there is a systemic blood pressure drop? Is it because of decreased venous return to the left heart? Is it increased pulmonary vascular resistance? Is it increased systemic vascular resistance? Is there decreased RV filling? So please remember, when you have a good inspiration, there is a decrease pulmonary vascular resistance. There is an increased RV filling. The systemic vascular resistance will fall, but that is primarily due to a decreased venous return to the left heart. So the answer here is a decreased venous return to the left heart. So whenever we inspire, there is an increased venous return to the right heart. The septum will shift to the right side. It will, from the right side, increase filling. So the septum will push to the left. The left ventricular volume will be decreased. That's very important. So preload to the LV is decreased. And there is a decreased systemic arterial pressure also will decrease because of that. The decreased stroke volume to the left side is the primary reason for that. Students, I think we have discussed some of the common questions which have, by the recalls, we have got it. There have been other questions which people have told about, some of them based on our, maybe a rheumatic heart disease. There was a question that was discussed regarding rheumatic heart disease, where major or minor criteria were asked. I think that has been discussed with your pathology sessions might be discussing that part as such. So I think there was erythema nodosum given and arthralgia, polyarthralgia, short PR interval was there. And there was, I think, chorea that was given. So what is not seen in rheumatic fever is the erythema nodosum. It is erythema marginatum that is seen. And you have a prolonged PR interval, right? It's not a short PR interval that is there. You have had a lot of questions which are related to medicine, but primarily pharmacology. I think that will be discussed in detail in the pharmacology session. So I hope we have discussed most of the questions which have come directly from the medicine, and I have possibly discussed many of how do you rule out. The questions were straightforward and they were clinically related. So it would have been easy if you had a good sound base of your first and second year, the pathophysiological mechanisms, you'd be easily able to eliminate this and get to the correct answer. And we have discussed most of these questions in our prior sessions as well as in your PYQ discussions. Most of these were, and quite a lot of questions came from the high yield topics itself. So let's hope and wait for the results soon, and wish you all the best for your results. Thank you.